Since the early part of 2000, hospitals have been asked to publicly report about certain outcomes. The idea, of course, is that by making us be more public about our outcomes, we'll be more accountable, and the quality of care will more consistently be evidence-based, and patient outcomes will improve. Starting first with just a small number of accountability outcomes and then adding more, leaders of that movement, most notably the authors of this particular citation that I have here, come from the Joint Commission, and they've worked with the Centers for Medicare and Medicaid. They believe that the proof of concept phase is complete and that this works. So here's some evidence to support that from that same publication from the New England Journal of Medicine. In 2002, the Joint Commission required that accredited hospitals report on at least 2 of 4 core measures. That may seem like just a few, but that was 2002, and now you have many more to deal with. But these core measure sets reflected the best available evidence, and this was the first time that hospitals used standardized measurement in the United States. 2002 was the first time that we used standardized measurement. These core measures represent whether or not well-supported therapies have been given to all the appropriate patients. Using a threshold of at least 90% compliance with the treatment, it's clear that since the public reporting began, compliance has greatly increased. This graph represents the percentage of hospitals that have met a threshold of 90% compliance. And in this case, it is whether or not patients were given an ACE or an ARB for left ventricular systolic dysfunction. In 2002, under 20% of hospitals met that bar. And in 2009, nearly 90% have met that goal. The story is even more impressive when we talk about giving beta blockers to people who have had an MI, acute MI, by discharge. The percentage of hospitals who have met the bar of 90% adherence rose from just 49% in 2002 to nearly 97% in 2009. Furthermore, in 2009, 98.3% of all eligible patients received beta blockers compared with just 87.3% in 2002, and this comes from Joint Commission data. Similarly, with regard to antibiotics be given 1 hour before surgical incision, there was a sharp trend from hardly anyone getting it right in 2002 to over 90% getting it right in 2009. For stopping antibiotic use within 24 hours of surgery, this is and continues to be a little bit harder than getting it started, but compliance is still much stronger in 2009 than it was in 2002. Not only have these individual measures improved, but overall, the opportunities to use the core measures has grown by orders of magnitude. And the percentage of hospitals meeting that 90% compliance rate or better on all core measures has increased from just 20% in 2002 to nearly 86% in 2009.